Hello everyone. Today's lecture will be on suturing. The learning outcome of this lecture, we will define what is suturing. We will discuss about the indication or contraindication of suturing. We will talk about the type of sutures available, the surgical suturing instrument and surgical suturing needles that is commonly used, and we will talk on the suturing technique. A suture is a strand of material used to ligate vessels and reapproximate lacerated or incised tissue. Surgical suture materials are used in the closure of most wound types. The ideal suture should allow the healing tissue to recover sufficiently to keep the wound close together once they are removed or absorbed. Surgical stitching is a process to close a wound or incision or to approximate parts and play a significant role not only in obtaining primary closure for ideal healing. The suture will coapt wound margins to hold the tissue in position and approximate the opposing wound edges. The sharper the incision and less trauma inflicted on the wound margin, the more probable is healing by primary intention. If the space between the two wound edges is minimal, wound healing will be rapid and complete. But if tears or excessive trauma to the wound edges occur, wound healing might need to occur by secondary intention. So what is the indication of suturing? To repair skin tissue, to facilitate proper skin healing, to minimize bleeding, to minimize bacterial contamination, to help achieve skin hemostasis, to restore the normal function of the injured body part, and to produce pleasant cosmetic. So what is the principle that govern our suture selection? There are a few things that we are looking at. One is the healing characteristic of the tissues, which are to be approximated. Second, the physical and biological properties of the suture materials. Third, the condition of the wound to be closed. And fourth, the probable post-operative cost of the patient. The ideal suture should have all these properties. One, it can be utilized in any operation. Second, it can be handled easily and comfortably. And there should be minimal tissue reaction. And the suture should have high breaking strength, should have high knot security. The suture shouldn't cut, tear, or shrink the tissue. The suture is not allergenic and non-carcinogenic. The suture is absorbed predictably with no tissue reaction, and the suture should be reasonably priced. Now let's look at some of the suture's physical characteristics. First, the physical configuration. This is where we are talking about monofilament or multifilament, twisted or braided sutures. Then the tensile strength. This is where, or it can be defined as the weight required to break a suture divided by its cross-sectional area. This can be identified by a different number of zeros. The knot strength. This is defined as the amount of force needed to cause a knot to slip. It is proportional to the coefficient of friction of the material. The elasticity is the ability of a suture to regain its original form and length after being stretched. The plasticity, on the other hand, is the ability of a suture to expand when stretched but not to return to its initial length. And the memory is the ability of a suture to return to its former shape after being manipulated. This reflects of its stiffness. Okay, now let's look at the classification of suture material. Suture material can be classified according to a number of factors. One, according to the fate, meaning absorbable or non-absorbable. Second, according to the source, either the suture material is naturally or synthetic. Suture material also can be classified according to the structure, meaning monofilament or multifilament. It can also be classified according to the coating, meaning the suture are coated or uncoated, dyed or undyed. Suture material also can be classified according to the tissue reaction, meaning reactive or non-reactive. and it can also be classified according to handling, meaning whether it's easy or difficult to handle. What are the instruments needed for suturing? There are basically three instruments needed. One, the needle holder, the tooth pickup or tooth forceps, and scissors. Now let us look at needle holder. The needle holder is an instrument with a locking handle and a short blunt beak. For intraoral placement of intraoral suture, a 6 inches needle holder is usually recommended. The beak of a needle holder are shorter and stronger, and the face of a beak of the needle holder is cross-hatched. This is to permit a positive grasp of the suture needle, meaning increasing the control over the needle and the suture. So this is example of a needle holder. You can see a locking handle, and if you look at the face of the beak, it has a cross-hatch appearance. To control the locking handle of the needle holder properly and to direct the beaks of the needle holder, the surgeon must hold the instrument properly. So how to do it? The thumb and the ring finger are inserted through the rings of the handle. The index finger is held along the length of the needle holder to steady and direct it. This will aid in controlling the locking mechanism. The index finger should not be put through the ring finger because this will result in a dramatic decrease in control. So here you can see the thumb and the ring finger in the ring, inside the ring of the handles, and the index finger is positioned at the length of the handle to stabilize the instrument. Okay, so these are the suturing instrument needed: scissors, tissue forceps, and needle. For tissue forceps, the most commonly used is accent forceps, or also known as pickup. These are delicate forceps with or without small teeth at the tips, which can be used to hold tissue gently and thereby stabilize it. Care should be taken not to grasp the tissue too tightly, otherwise it will crush the tissue. Tufted forceps allow tissue to be held with a more delicate grip than untoothed forceps. Okay, next we are looking at the surgical needle. Anatomy of a surgical needle. There are many different sizes, shapes, and types of surgical needles. The needle size is an important factor for a successful surgical operation. The needle should move through the tissue with minimal tissue reaction and minimal tissue damage. All of the surgical needles used today are eyeless needle. Sutures are combined. The eyeless needle is where the sutures are combined with needles during manufacturing by the manufacturer. This is by creating a channel for the suture at the tip of the needle. The needle and the suture are combined for a smooth transition. The needle and the suture thickness has a thinner structure compared to the eye needle. The surgical needle is called an atraumatic needle. Suture size is commonly indicated by the United States Pharmacopoeia (USP) system and is a measure of tensile strength. Tensile strength is defined as the amount of weight required to break a suture divided by its cross-sectional area. In the USP system, the number of zeros inversely correlates with the size, meaning the higher the number of zeros, the smaller the size and the lower the strength. For example, a 3O suture has a diameter that is approximately 2 to 4 times larger than a 6O suture. In general, larger suture size is associated with greater inflammation and scarring. So this is an anatomy of the needles. You have the needle points. Here is the needle length. Needle length. This is swag area where you have the needle and the suture material fused together. Then you have the needle radius. This is the body and needle diameter. Right. Now look at the needle shape. There are many different types of needle shape. We have straight needle, This surgical needle can be used without a needle holder, and this can generally use in easily accessible tissue. We also have a quarter circle needle. This surgical needle is used in the convex surface and sensitive surgeries. It has a slight curvature. We also have a 3/8 circle needles. These are needles generally used in larger and superficial wound. We also have a half circle needle. This is used for tissues such as skin, muscle, peritoneum, and eye. We also have 5/8 surgical needle. This needle which make it easier to maneuver in smaller area, are mostly used in deep and closed cavity. We also have what we call J needle. This is used mostly in cleft palate surgery and laparoscopic surgery with deep incision. So this is just to show the half circle needle, 3/8 needle, a 3/8 circle needle, quarter needle, and also 5/8 circle needle. And this is the straight needle. Commonly, the surgical needles are made from stainless steels. They are composed of the swage end, which connect the needle to the sutures. The needle body or shaft is the region grasped by the needle holder. The needle bodies can be round, cutting, or reverse cutting. Round body needles are used in friable tissue such as liver and kidney. Cutting needles are triangular in shape and have 3 cutting edges to penetrate tough tissue such as the skin and the sternum, and have a cutting surface on the concave edge. Reverse cutting needles, on the other hand, have a cutting surface on the convex edge and are ideal for tough tissue such as tendon or subcutaneous sutures, and have reduced risk of cutting through the tissue. So needle points for use on the skin are triangular. Needle points for use on the skin are triangular. We have reverse cutting. This is where the cutting edge is located on the outer or convex curvature of the needle and perpendicular to 2 other opposing cutting edges. This type of needle is preferred for most of skin closure. Conventional cutting, this is where the cutting edge is located on the inside or concave curvature of the needle and are perpendicular to 2 other opposing cutting edges. This conventional cutting needle may be prone to cut out of tissue because the inside cutting edges cuts towards the edges of the incision or wound. Thus, conventional cutting needle should be avoided for closure of skin laceration. This is just to show the needle point geometry. Here we have tapered point, which is suited to be used for soft tissue. It dilates rather than cuts the tissue. Here is a reverse cutting, which is very sharp, ideal for the skin, but it cuts rather than dilates. Here is the conventional cutting. This is also very sharp. It cuts rather than dilates, so it creates weakness, allowing suture tear out. This is tapered cutting. This is ideal in tough or calcified tissue, but mainly used in cardiac and vascular procedures. For most traumatic skin laceration, the clinician should choose a suture needle with the following characteristic: reverse cutting, 3/8 curvature, and label for use on the skin, for example, FS, CE, P, and etc. Standard skin needles such as FS for skin or CE or cutting edge series are suitable for closure of scalp, trunk, and extremity laceration. Plastic needles are smaller and more sharply honed for use during closure, requiring precise approximation, for example, for facial laceration, and are indicated by acronyms such as P stand for plastic, PS plastic skin, PC precision cosmetic, and PRE plastic reconstruction. So let's look at suture material. What are the requisites for suture material? The requisites are: the material should have high uniform tensile strength and should permit use of finer size. The material also should be secured throughout the critical healing period, followed by rapid absorption. The suture material also should be sterile, pliable for ease of handling and not security, and should be biologically inactive. The suture material also should free from irritating substance or impurities for optimum tissue acceptance. The suture material also should have predictable performance. It also should prevent or limit bacterial adhesion and proliferation. And suture material also should have uniform diameter and should be non-carcinogenic. Broadly, sutures material can be classified into absorbable or non-absorbable material. They can be further subclassified into synthetic or natural sutures and monofilament or multifilament sutures. The ideal suture is the smallest possible to produce uniform tensile strength, securely hold the wound for the required time for healing, then be absorbed. It should be predictable, easy to handle, produce minimal reaction, and not secure. So this is just to show the classification of suture material. We can have absorbable, non-absorbable. Absorbable can be classified into synthetic or natural. Non-absorbable can be classified also into synthetic or natural. So let's look at the absorbable suture. These are made from naturally occurring material that break down when placed in the skin. The breakdown process is by enzymatic reaction or hydrolysis. Example is chromic catgut, which consists of processed collagen taken from the submucosa of animal intestine. Chromic gut breaks down after 7 days, but it is treated with chromium salts to delay the breakdown process, allowing it to maintain its strength for up to 2 to 3 weeks. Absorbable sutures are completely absorbed by the body, and the duration or the timing for resorption varies. For example, Vicryl Rapid takes 42 days to resorb, Vicryl 60 days, and Monocryl 100 days. Synthetic absorbable sutures, for example, Vicryl and Monocryl polymers, are broken by hydrolysis. So this reduced tissue reaction that have been linked with chromic catgut. For non-absorbable sutures, these are made from silk, nylon, proline, and muslin. These non-absorbable sutures cannot be broken down by the body enzyme or even through hydrolysis. They are removed once the skin has sufficiently healed and regained its tensile strength up to a certain extent. Non-absorbable sutures are used to provide long-term tissue support, remaining walled off by the body's inflammatory process or until removed manually if required. The specific length of time that the suture is removed is different in every situation, but tends to follow a general pattern depending on the location of the suture. For example, facial sutures are removed within 3 to 4 days, while scalp sutures within 5 to 7 days. Let's look at the synthetic and naturally produced synthetic suture material. So for natural suture material, this is made of natural fibers, for example, silk or catgut. This is less frequently used as they tend to provoke a greater tissue reaction. Synthetic suture material comprise of man-made material, for example, the PDS or nylon. It tends to be more predictable than the natural sutures, particularly in their loss of tensile strength and absorption. The other important factors about suture materials are the structure of the suture material itself, meaning monofilament or multifilament. Monofilament sutures is a single-stranded filament sutures, for example, nylon, PDS, or proline. It has a lower infection risk, but also have a poor knot security and ease of handling. Multifilament sutures are made of several filaments that are twisted together, for example, braided silk or Vicryl. This is easier to handle and hold their shape for good knot security, but yet can harbor infection. So these are the example of sutures available in the market. Now we have Vicryl, which is absorbable and multifilament, PDS, absorbable and monofilament, Monocryl is an absorbable suture and monofilament. Nylon is non-absorbable, also monofilament. Prolene uh, uh, is non-absorbable and monofilament, whereas silk is non-absorbable and multifilament. Right, before we can do any suturing, we need to assess and evaluate and properly manage the wound. Okay. Wound evaluation involve a number of factors. One, the mechanism of the injury. The mechanism of the injury, right? Meaning either injury by sharp or blunt instrumentation, the wound ages, the degree of contamination of the wound, the presence of a foreign body in the wound size and the depth, the presence of neurovascular compromise, any injury to the adjacent structure, is there any need for tetanus prophylaxis, and potential for impaired wound healing. So these are the factors for wound evaluation. What is the contraindication for primary closure? Primary closure is contraindicated in laceration wound. Laceration wound which have deep punctured, laceration wound that have been grossly contaminated with foreign debris, and laceration through infected skin. So primary closure is contraindicated in laceration wound, deep punctured laceration wound, or in laceration wound that have been grossly contaminated with foreign bodies, or laceration wound through infected skin. Primary closure is also contraindicated in superficial wound that would be expected to heal without significant scarring, such as laceration or abrasion that only involve the epidermis. Suturing in this wound will potentially cause increased scar formation and risk for infection. Primary closure is also contraindicated for laceration wound with significant tissue loss. So what is the proper wound management? Before we can suture the wound need to be properly managed. There are 5 principles in wound management: cleansing, debridement, hemostasis, wound closure, and therapy. So before we do any cleansing, we need to give sufficient local anesthesia. This is to reduce pain. Then wound debris should be removed prior to dressing application. This is to facilitate both repair and assessment. So wound cleansing can be performed by using normal saline, which is a sterile solution. It has non-toxic and no adverse effect on healing. We can also use hydrogen peroxide, which has oxidizing effect. It can destroy anaerobic bacteria and remove slough from the wound. We can also use chlorhexidine, which is a broad-spectrum antimicrobial agent, or we can also use povidone iodine, which also have a broad-spectrum antiseptic property. Wound debridement is performed in order to reduce number of bacteria in the wound and also to remove devitalized tissue and jagged pieces of wound surfaces. By removing devitalized tissue or jagged pieces, this will improve blood supply to the wound edges and create a better tissue approximation during hemostasis in the wound is very important before we can start suturing the tissue. So how to achieve hemostasis? We can use direct pressure. If there is bleeding from the bone, we can reduce the fracture. We can also use hemostatic agent, for example, bone wax, Surgicel, adrenaline, cellulose oxidized collagen, or gelatin. We can ligate the blood vessels. We can use cauterization, for example, electrocautery or canal solution. We can also use suture to achieve hemostasis in the wound. After we have done a proper cleansing, wound debridement, and also hemostasis have been achieved, we can start closing the wound. So closure, or we can close the wound with suture. We can use absorbable suture for intraoral or inner layer of the wound. Here we can use Safil, Vicryl, or Dexon. We can use non-absorbable suture for extraoral wound. Here we can use silk, ethylon, or silcum. Wound with greater tissue loss may need to be undermined in order to minimize wound contraction. Deep wound suturing should be done by layer by layer technique, meaning we should suture from the deepest part of the wound to the skin or mucosa. For through and through wound, the suturing should start from intraoral, meaning we have to create an intraoral barrier in order to prevent pooling of saliva in the wound. This is to minimize wound contact. Okay, now let's look at the principle of suturing. So how to do a proper suturing technique? The needle holder should grasp the needle at approximately 1/3 of the distance from the end. The needle should enter the tissue perpendicular to the surface. If the needle pierces the tissue obliquely, a tear may develop. So this is how we hold the needle, about 1/3 from the swag area. Okay, how to insert a suture? In general, we place the first suture in the midline of the wound. Okay, so we load the needle holder, grabs the needle at a 90-degree angle with the very tip of needle holder, grab the needle at the junction of the proximal and middle third of the needle, meaning 1/3 from the swag area. Then use the tip of the forceps as a hook, or we can use a tissue hook to gently lift the tissue and evert the wound edges as needed while the sutures are being placed. Proper wound edge eversion during this step is essential to optimal approximation of the dermis, which ultimately helps maximize the strength and minimize scarring of the healed wound. Then place sutures by gently supinating your wrist so that the needle follows its curvature through the skin. The needle should enter and exit the skin at a 90-degree angle. Match the bite depth and the bite width on both sides of the laceration. The bite depth should be greater than the bite width. Then push the needle through both wound edges. Gently pull the suture through the path of the needle and leave some about 2 to 3 centimeters of the free end of the suture material exposed. And release the needle from the needle holder and allow the needle to rest on a sterile trap. Then tie the suture using an instrument tie. Repeating these steps, place all subsequent sutures in the middle of each open section until there is no remaining gaps in the wound. Spacing between sutures is typically equal to the distance from needle entry to wound margin. So then, how to do the instrument tie? So hold the tip of the needle holder above and between the entry and exit side of the suture. Use your non-dominant hand to manually hold the long end of the suture, the needle end. Then to lay down the first throw of the knot, wrap the needle end, the long end of the suture over the end of the needle holder twice. Wrapping twice forms the base of the surgeon's knot, which prevent the first throw from loosening. Next, rotate the needle holder 90 degrees and with it grabs the free, meaning the short end of the suture. Then pull your hand in the opposite direction to lay down the first throw securely, but not tightly. Tight sutures risk cutting into the skin and causing ischemia as wound edema develops after the next several hours. On the second and subsequent throw of the knot, wrap the needle end of the suture over the needle holder only once. Grabs the free end of the suture with the needle holder and pull in opposite direction to tighten the knot. These subsequent throws may be pulled tightly. Note that the suture is always drawn over the needle holder and that your hand move in alternating direction across the laceration with each throw. Adhering to this method assures that all knots are square knots. Place a total of about 4 throws. After the final throw, cut the suture with a scissors, leaving tails about 1 centimeter. Now, let's look at the suturing principle. There are a number of principles that we need to follow in order to get a good suturing result. First, the needle should be passed through the tissue following the curvature of the needle. Second, the suture should be placed at an equal distance from the incision on both the sides and at an equal depth. Third, the needle should pass from the free tissue to the fixed side, meaning free to fixed. Next, if one tissue side is thinner than the other, the needle should pass from the thinner tissue to the thicker one. Okay, thinner to the thicker one. Next, if one tissue plane is deeper than the other, then the needle should pass from the deeper to the superficial side. Deeper to superficial side. The other thing that need to be considered is the distance that the needle is passed into the tissue should be greater than the distance from the tissue edges. The distance that the needle is passed into the tissue should be greater than the distance from the tissue edge. The other thing that we have to remember that we should avoid excessive tissue bites with small needles, as it will be difficult to retrieve them. The next thing to remember is that the tissue should not be closed under tension, since they will tear or necrosis around the suture. If tension is present, the tissue should be undermined to relieve it. Okay. The suture also should be tight so that the tissue is merely approximated and the edges are evented. And the knot should not be placed over the incision line. Suture should be placed approximately 3 to 4 millimeter apart. And closer spaced sutures are indicated in areas of tension. So in areas of tension, you can do a closer spaced sutures. Okay, now a bit on the knot. This is the component of a knot. The loop is created by the knot. The loop is created by the knot. The knot itself, which is composed of a number of tight throws, each throws represent a width of the two strands. The ears, which are the cut end of the sutures. So this is the component of the knot. You have the ears. Okay, this is the loop. This is a loop. So square knot, this is suture knot, which is made by tying two overhand knots, each done in opposite direction. For example, the first loop is made by making a loop over the jaw of the needle holder, and the second knot is subsequently made by forming a loop under the jaw of the needle holder. This knot is easy to tie, but may loosen when a synthetic or monofilament suture material is used. Surgeon knot, on the other hand, is used primarily with braided suture material, whether synthetic or natural. The surgeon knot is a modified square knot in which the first overhand knot is double. Therefore, two loops of the suture are formed over the jaw of the needle holder and tightened. The last loop is formed under the jaw of the needle holder in a direction opposite from the first loop. Okay, so this is the surgical knot or the surgeon knot. Now, let's look at the suturing technique. There are a number of suturing techniques that we should know. One, the most commonly used, is simple interrupted suture. Then we have continuous subcutaneous suture, continuous subcutaneous interlocking suture, continuous skin suture, mattress suture, and buried suture. Okay. Simple interrupted suture. This is where the sutures are individually placed and tied. This need to be repeated for many times as required depending on the wound length. Simple interrupted has less potential for causing wound edema, and it allows the surgeon to make adjustment as needed to properly align wound edges. This is the technique of choice if cleanliness of wound is doubtful. If the wound appears to become infected, a few sutures can be removed without interrupting the entire closure. The disadvantage of simple interrupted suture is that more time is required to place interrupted sutures and more risk of cross-hatching train tracks across the suture line. The latter however, can be minimized by early suture removal. Okay, so this is how the simple interrupted suture looks like. It is very strong and can be used in areas of stress. Each suture is independent, and the loosening of one suture will not produce loosening of the other. Degree of eversion can be controlled, and it is easier control of infection and or hematoma. So how do we do simple interrupted? So to introduce the needle into the wound area, so we can apply this principle out to in to out. For out to in principle, this is where we gently lift the skin with the forceps and pierce the skin surface with the needle perpendicular to the skin. Then supinate your wrist so that the needle passes through the dermis and rises out of the middle of the wound. Then use your forceps to hold the needle whilst you release your needle holder. Then re-grasp the needle in the same place with your needle holder. Then you use the in to out principle to reintroduce the needle on the opposite side of the wound edges. So in to out, this is where you lift the opposing skin edge gently with your forceps. This time the needle has to travel perpendicular through the dermis from inside to outside. Using the curvature of the needle and supination of your wrist, move the needle through the skin. You should have equal needle bites of the depth and distance from the wound. Should have equal needle bite of depth and distance from the wound in order to allow wound edges to oppose equally and neatly. Again, use your forceps to grasp the needle and pull it out through the skin. You should now have a suture crossing perpendicular to the wound. Then you can do the surgeon or you can do the square knot. Okay, these are examples of simple interrupted sutures. Continuous subcutaneous suture, also known as subcuticular continuous suturing. This is more resistant than a simple suture. Continuous sutures may be performed more rapidly than simple stitches. It is useful in situations with minimal wound tension and dead space, and when the best cosmetic result is desired. It can result in minimal visible suture marks, little cross-hatching, as well as closely approximated wound edges. However, it does not contribute to the wound strength, and there is the risk that a wound may split or burst open if the suture breaks. So this is what we call subcuticular continuous suturing or continuous subcutaneous suturing. Suture is introduced at the tip of one wound edges, okay, through the skin, and then it goes underneath the skin. The needle is introduced subcutaneously and then come out at the other end of the wound edges. Then you can pull the two ends of the sutures and the two wound edges will be approximated nicely. The next technique is continuous interlocking suture. This is a variation of the continuous subcutaneous suture. The interlocking suture technique provides extra resistance. It retains most of the tension, thus enabling surgeons to perform a tension-free skin suture. The interlocking suture also can act as an anti-slippage suture. In this suturing technique, threads provide higher friction at each passage, which in turn give a firmer hold during suturing. It also ensures that stitches will not loosen when the next passage is performed. The continuous subcutaneous interlocking suture has a high tensile strength, which is extremely useful on wounds under high tensions or in case of highly vascularized tissue requiring additional hemostasis. It can impair microcirculation and can cause strangulation. So it should only be used in areas that are adequately vascularized. So this is example of continuous interlocking suture. You can see how the strength of the suture is interlocking between sutures. Then we have continuous over and over skin suture. This is primarily to be used with tension-free wounds, in which deeper sutures are placed so as to minimize the wound tension. Continuous skin sutures can typically cause less scarring as it involves the use of lesser knots. Continuous skin sutures are also placed rapidly, but there is also the risk that the wound may burst open if the sutures break. The continuous skin suturing technique is generally used for securing the perimeter of a split or a full thickness skin graft. Okay, so this is how continuous over and over suturing looks like. Okay, how the sutures going in and out continuously from both wound edges. So it provides a rapid technique for closure, distribute the tension uniformly over the suture line, and offer a more watertight closure. Okay, another example of over and over suture. Okay, mattress suture. This is used when wound edges are not close to each other, thus allowing tension-free healing. Mattress suture can be used to ensure the eversion of the wound and to minimize substantial wound tension. They are predominantly used in areas in which the edges of the wound tend to invert, for instance, wounds on concave surfaces. The suturing technique has two variants, horizontal and vertical mattresses suture technique. The horizontal suture helps with minimizing wound tension and closing dead space. It also facilitates wound edge eversion. The vertical suture, on the other hand, is regarded as one of the best suturing techniques that ensure wound eversion while also reducing wound tension and dead space significantly. Okay, so here we have example of vertical mattress, example of vertical mattress, and this is horizontal mattress. Okay, vertical mattress and horizontal mattress. Finally is the buried suture. Buried sutures are a useful technique for wide gapping wounds and wounds where eversion is difficult. The purpose of this stitch is to line up the dermis and thus enhance healing. The knot needs to be as deep into the tissue as possible, meaning it is buried, so that it does not present through the epidermis and can cause irritation and pain. This suture is extremely important for distributing wound tension to the dermis rather than the dermis, and also for closing that space. The buried suture also provides longer term support to the healing wound and improve the cosmetic result. Here we can see how we do a buried knot, buried suture. The wound edge is everted with skin hook, and then an absorbable suture is introduced at the subcutaneous level and brought back out at the dermal level on the same side of the wound. And the needle is then reintroduced, or the needle then enters the same dermal level on the opposite side of the wound and exit in the same subcutaneous level as it was initially entered into on the first side of the wound. The knot is tied deep at the subcutaneous level and the free end is cut short. Okay. So this is where you introduce the needle into the wound edge. Okay, then the needle come up. The needle come up at the upper end of the wound, and then reintroduce at the same level of the upper end of the wound, and the needle is then pushed out from the deepest part of the wound at the same level as the first entry point. Then the knot is tied. The knot is tied together and it is buried deep in the tissue. Okay, now I just want to show you example of the commonly used suture technique in dentistry. This is one of the the most common one that being used, interrupted simple suture, where you can suture the interdental papilla. You can suture the interdental papilla with a simple interrupted. You can also use vertical mattress. You can use vertical mattress. You can use a vertical mattress to suture the interdental papilla instead of the simple interrupted suture. Here you can use a horizontal mattress, to suture both end of the interdental papilla. See, you can use a horizontal mattress to suture both interdental papilla together. We can also use a figure of 8 suture. This is commonly used when the tooth socket is packed with a surgicel or gel form. So in this case, the needle is passed at the, for example here, is passed at the distal buccal papilla, and then it comes out through the mesolingual papilla, distal buccal to mesolingual, and then reintroduce through the mesobuccal of the papilla, mesobuccal of the papilla, and come out through the distal lingual of the other papilla. Then you can tie the suture together, and it will appear as a figure of 8 suturing. This is what we call a sling suture. Okay, this is what we call a sling suture to hold the periosseum and the interdental papilla together. Okay, so after the suturing, what are the supportive therapy that need to be given to the patient? So we need to consider giving analgesia to the patient. Painkiller need to be given to control pain level. And then depending on the tetanus status of the patient, ATT may need to be given to the patient. And then we need to advise on a proper post-surgical diet. Need to advise also on the proper wound care. Very important, because you don't want the wound to get infected. And depending on the age and the degree or severity of the wound, antibiotic may need to be considered. Okay, so when the patient came back after a certain period of time, the suture need to be removed. So a proper way of removing a suture, okay, when we are cutting the suture, you have to cut the suture end very close to the skin or to the mucosa. This is to prevent the introduction of the organism that harboring the sutures on the outer part from entering the subcutaneous or submucosal tissue. So after you have cut one end of the suture, pull the suture towards you. Pull the suture towards you. This will prevent the wound edges from gaping. If we look at this one, if we pull the suture away from you, away from our body, you can see how the two ends of the suture open up. So it has to be this way. You cut close to the mucosa or to the skin, and then pull the suture towards you. Okay, the last slide is just to indicate the complication of suturing. Suturing can cause scarring. It has a potential to cause infection. It has a potential to cause keloid formation. It can also result in poor skin healing. And suturing also can cause ischemia and necrosis due to excessively tight suture. Okay, with that, I thank you.